Okay. Wow. Awesome. You guys are all amazing for time. It's 10:30, so we're going to get started. So thank you for coming. My name's Kim North, and I'm just volunteering for the Elder Connect program. I think you're probably all aware of that program by now. And it offers different programs to seniors, including the Better at Home, including recreational activities, educational stuff. And this is one of the second sessions on death and dying workshops that we've been having. So the first one, just in case, I noticed there's quite a few people here that didn't attend the first workshop, but we had a full day workshop on putting a life plan together, like an end-of-life plan. And this booklet here has been put together by us, and there's a checklist here. And if you go slowly and surely down the checklist, you will have all the documents you need in this binder. Did anyone who came to the workshop, have they actually done any of this work yet?
No.
Come on. Oh, the couple. Okay. And Bob is done. He's getting stuff signed today. Is anyone getting things signed today from these documents? So we have 1, 2, 3 people. Okay, perfect. So just remember, this document is kind of like a living document, and just keep going through it and fill it out and put all of your documents into this one binder, and it just makes it so much easier. Because when I was trying to do it for myself, the information was just all over the place. And so I made myself a checklist, and so then I thought, we should just have a workshop on this. And so it was well received, and we can have another one if people are interested. To pick up one of these, you just have to go to the Community Connect Hub, the orange building beside the post office, and just ask them, and they might not be able to give it to you right away. They'll print it off and put it in a binder for you, and you'll be able to pick it up there. So just contact Elder Connect, and you'll be able to get those. So today, we're going to be talking about MOST, which is medical orders for scope of treatment. And this was one of the paperwork that was in your binder. This one has to be done with a doctor. And we have
or a nurse practitioner.
Or a nurse practitioner. So we have with us Dr. Terry Miller, and who is an expert especially on MAiD in particular, right?
Yeah, I'm not. Ian's the most.
And then we have retired Dr. Ian Routley, who everybody probably knows, and we miss him a lot. But he's here to talk a lot about the this MOST form. But they're not here to sign the forms for you today. You have to make an appointment to see your doctor, right? So they're just giving us information on both MOST and MAiD. And then these other 3 forms, we do have someone at 12:30 coming, and these are the other 3 forms that need to be signed and, with a notary republic. Is that how you call it? Notary public has to witness it. So there's 3 forms, and they're in your kit. If you want to know more information about that, you can come and see me later. Okay, so just a little bit of housekeeping. There is some food over there, all Canadian. There's a washroom, except the oranges, of course, they're from Mexico. But if you just go outside this door and into the library room next door, across the hallway, there is a toilet there just on to your right. So if you need to use the washroom. Okay, so we'll get started. So thank you to Ian Routley for coming, and Dr. Terry Miller. 2 long-term doctors that have been that have practiced and are still practicing in our community. Well, Terry's still practicing. So, do I need to say anything else?
No, that's good. And I want to say, don't panic. Can you all hear me first off?
Yeah.
Don't panic if you haven't done these forms Kim's talking about. You don't want to rush this stuff.
No.
You want to spend time to talk to your family members. Pick someone who might be your alternate when you can't speak for yourself, because that's probably one of the most important things. If you're able to tell what you want and speak to the physician in front of you, it doesn't matter. You could do it, that's great. It's when you can't speak for yourself. So you want to pick someone that you respect, will talk with you, are curious about what your wishes are. So how many people have either a MOST or an advance directive done? How many people understood all of what was on there when they were doing it?
Oh,
great. That's
some
great.
people did.
That's great. Because that's what actually Kim originally told me to do this, to talk about MOST, but I put that up there first anyway, just because I thought there'd be people here who may not have attended some of our other workshops. But yeah, having an advance directive doesn't have to be a complicated thing. My mother's sister, who lived to 100, born in the last pandemic, died in this one, not from COVID. She was a school teacher, and I was her medical decision maker. So she and I went back and forth. She'd say, what about if this happens? What do I do? What about if this happens? What do I do? She made it very, I don't want to say nuanced. It was like down to the T. She was obsessive about how she wanted it filled out. You don't have to do that. What you really want to do is decide what your values are, what you're willing at that stage in your life to live with. So I had recent surgery. I have no family history of heart disease, but I told him, if I have a heart attack on the table, I want you to do everything, because I had a good chance, even though I look in the mirror and say, what the hell happened? I had a good chance that I'd survive some kind of a cardiac arrest on the table. Now, my aunt, at the end of her life, we'll talk about palliative care in a bit, but she had a procedure done called a TAVI, which stands for Transaortic Valve Implant. And that was done as a palliative care measure. It wasn't done to treat her or cure her, but many people would say that's super invasive to have done. She was in her 90s. She was 96. But she was back and forth to Nanaimo Regional General Hospital multiple times because she'd wake up in the middle of the night and couldn't breathe. And if any of you have ever had that sensation that goes on and on and on, you want to relieve that. You want to get rid of it. Her GP at the time, who I'd known for years, had heard her, and as had I, as her medical decision maker, had heard her talk about not having anything done at the end of her life. She didn't want any treatment. But it was kind of a no-brainer. Like, she could live for another decade like that at that age, the way she was going. And that, I mean, this was happening every 2 or 3 weeks, sometimes every week. So we went ahead and talked to her about it, and that's what she ended up having. She lived another 3 years with a good quality of life. And then, as I say, she passed away in this last COVID pandemic. But that's... kind of lost my train of thought, guys, here. But the MOST is a different thing. It's less nuanced. It's sort of black and white. The thing is, you can change your mind on these things at any time. When you're in the hospital, having a discussion with your physician, you may want all the treatment done, but after discussing with the physician, the odds of you surviving a certain procedure or the odds of you recovering from a certain situation may be low enough that you decide you don't want A, B, or C. And I'll go over the MOST form when we get to it. But the best time also to start with this is when you're healthy. Don't do it as a physician, there was nothing worse for me than having someone in extremis, and I have to try to decide what they want. Because as soon as I start talking about this stuff with someone who can't breathe or is having chest pain, they think, oh shit, I'm dying. And many times they are. But trying to get a really good feel for what their wishes are, that's not the time to do it. Right? Now, some people just don't. The second worst thing for me as a physician, especially when I first moved here, was people saying, I don't know, you're the doctor, you make the decision. I don't want to do that. As a physician, I never wanted to give advice. I knew what I wanted to do. I don't know what you want to do. So, very good to do this with your family and friends. Review it. Talk with people you trust. Do it early. Recognize not everyone in your family will want to talk about this. Even as a close to retiring physician, I had patients that would say, we don't want so-and-so to know what's happening to them. That's another awkward position to be as a physician. Way better to be open and honest, I think. Way better to talk about this stuff. Way better to not hide it from people. So, anyway, any questions about what I'm saying so far? Pardon me?
I think we understand.
Yeah, no, I think most people do. And also review when your circumstances or priorities change. Obviously, you may do a most when you're feeling healthy. You go into hospital, you get a catastrophic diagnosis. You may change what you want. I've actually seen families where they would tell me, the person would tell me, if I'm ever going to end up in Mountain View Lodge, I don't want anything done. But then they have a granddaughter who has a great-grandchild, and they want to see that kid delivered or born or go to school or graduate. Their idea of what is important at that stage in their life changes. So don't leave something sitting in paper without a person to make decisions for you when you can't make that decision, and arrive in the hospital saying you don't want anything done when you might want something done. So there's kind of a bit more of a range of ways to look at it. So, let's see. I can't remember if I had anything else. I have to do this or I'll forget what I'm going to say.
We all know that.
Yeah, no kidding. Join the club. No, I think I may have, let's just see here. Yeah, so Kim talked about palliative care. There's a lot of, what they now say the palliative care approach. Terry, did you do the palliative care course when they had it here? Yeah, did you do it recently?
No, I didn't think I needed it.
Yeah, so it's kind of, a lot of this stuff, it's semantics, and by that I mean they changed the wording so it makes better sense to people. But really, palliative care is an approach to a person who has been diagnosed with a chronic, potentially progressive, life-limiting disease. It does not mean that you don't get treatment. It does not mean that we don't try to cure the disease if possible. So let's say you walk into my office, I diagnose you with a type of cancer. Cancer is a term for a broad range of conditions. Some cancers, like non-Hodgkin's lymphoma, I know the chance is that we could probably put that disease in remission. But if you come in with a cancer that's spread throughout your body, the chances are very, very slim that we're going to be able to cure you. In fact, almost always the answer is we can't cure you. So if you came in with the first cancer, I would still approach you as a palliative care patient, but knowing that there's a good chance that you would be cured with the treatments we give you. This also doesn't just apply to cancer, and a lot of people don't realize that. So if you have quite severe lung disease, quite severe heart disease, neurological progressive condition, all of those conditions, despite modern medicine, we can't cure a lot of those things. And over time, things will change. So the focus of a palliative care approach just opens up how we try to treat people. It kind of, in a way, it's to try to tell doctors to do their job, in my opinion. Because a lot of times what we do is we confuse palliative care with what's called hospice care. And hospice care really is just providing comfort measures in the last 6 months of your life. We still treat symptoms and everything else, but hospice care is acknowledging that you're going to be probably passed away within 6 months, and so it's a total different focus. Whereas palliative care is still trying to, if possible, maybe not cure, but at least prolong or modify the disease progression. So that was one of the things Kim said that people wanted to know about, was what the difference between palliative care and MAiD, and they're not exclusively, I mean, you can work together with that. So if you have a palliative care approach and you've made the decision you want complete control on how you're going to end your life, then you can choose to opt for MAiD. And Terry will talk about that in a little while. Again, early start. Someone I see in the office with severe lung disease, they've had it for years. they can have a palliative care approach. It doesn't say, the lung disease may limit their time, their lifespan, but with proper care, you can sometimes improve. So if I start with someone early on with lung disease, they get proper vaccinations, they get proper referral to a lung specialist, they see physiotherapy that looks after lung disease. That's a lot different than me just giving them their puffers and sending them out the door. So it's a palliative care approach is something that thankfully is more common now. And as it says there, it's on improving the quality of life along with treatments to control disease. So I think that's kind of my bit on all this stuff. And if anyone has questions, please ask, because that's just at the end, the hospice care. Pardon me?
I have one of these made out, and I've chosen not, because I live out in the country.
We all do. You more than some, but
I live where I don't have self-service.
Yes, no, for sure,
so
Fred.
I chose M2.
Right.
And that means that if the ambulance has to come out and pick me up off the ground when I'm incoherent, that I don't want any resuscitation.
Right.
And however, as long as I can speak, I don't want that to be in effect. Mm-hmm. So
you can. What I said earlier is what holds with all of these things. If you're able to communicate, you are the one who chooses what actually happens to you.
Yes,
it's only when you can't communicate, and so that's where it's really good to have someone that you trust and have talked with, because let's say they come out and find you on the floor, and you've just tripped and banged your head, and you're unconscious, right?
Yeah.
I mean, they may take a different approach to you getting you to the hospital than if everything on the wall says no code, no anything. They're not supposed to, but they still may take a different approach. And if you are clear with your substitute decision maker, or you have a list of the kids that you want to be, because in your case, you'd have one of your offspring probably that would speak for you, possibly. I'm making an assumption, not a good thing. But if you have an alternate decision or a temporary substitute decision maker, let's say you've got 4 kids, and 3 of them don't speak to you. But when you're in trouble, sometimes they present to the hospital and try to speak for you. So, you want a temporary substitute decision maker list that lets people know who you want. And it is legally, I have to go with your spouse first, your kids, and you go down the list. And if those people aren't there, we end up with whoever is on that list. If you have the list, if you don't have the list, we have to legally kind of follow someone. Now in Lillooet, often we know a little bit about, we would know about family dynamics, and we know which family member might be not always the one you want to get the advice from. So I probably shouldn't admit that.
So what happens if you're traveling, let's say out of the area or in another country, and you get in an accident, let's say, and you're unconscious? Is there any information on your medical that is shared?
No, that's an excellent question. Yeah, no. So in BC, most places can, and correct me if I'm wrong, Gary, but you can find some of those documents, like a MOS form would often be on your medical record, so people could see that. But if you're not able to speak, the MOS form doesn't always have filled out your temporary decision maker, right?
Well, I wonder,
Depends on who filled it out
when
for
you're
you.
in an emergency, I doubt if many doctors are going to say, hold it, I want to check to see.
No,
Whether-
but they may try. I mean,
Yeah.
I've had folks over the years that have showed up in this emergency, and I try to find their family if there's someone with them.
Yeah.
If everyone in your car is unable to speak, I may be in a bit more of a bind, especially if you're say in South Korea or Antarctica or somewhere like that. It's not as easy to get a hold of people, but you do try if possible.
Another question is if the ambulance comes and you have no help, and they're obligated to help you, aren't they? They don't automatically know you don't want treatment or any of that stuff. They automatically have to help you.
Well, their focus is on trying to get you to definitive care. I mean,
there just one thing.
sorry,
you want to pass that to me?
Oh.
So see this document here? This has got your most form in it, and you can have your advance directive and other things in it. And the ambulance actually knows where to look on top of your fridge or inside your freezer, and they can look at it. So I'm not, they do look at it. So.
Yeah. Why would they know they got one on the other?
Because it's kind of a thing that the medical, like BC Interior Health, Fraser Valley Health, this is called a green sleeve, and it is something that the ambulance knows about. It's something that you fill out, you put all your important documents in, and it's supposed to be on your fridge or in your freezer, and the ambulance knows to look there. So if they don't see a green sleeve, then obviously they're going to do everything that they can. But if they see the green sleeve, it says on there. So that's an important thing to have on your fridge.
Where do we get that? Where do you get that?
You can get that also at either at Home Support, at Interior Health, or you can pick it up at the Hub. We have some there too.
When I asked my daughter about that, 35 years being a parent, she's been 35 years, she's never heard of it.
Oh, really?
And she's in Chetwood.
Well, that's interesting.
Those guys up north in BC.
I haven't done it. She's,
Okay, well, we should actually talk to our ambulance people here and see what they say.
Because I really wonder about that. Like if it's in your home, maybe they'll see that, or
Yeah, if you're out and about.
somebody else with you can tell them. But if you're out in a field,
Yeah.
or you're in Philo, or and that's what I wonder.
Yeah.
Is there a system, because it would be electronic on the system, your most interventions that you want.
Yes, they're
But
on.
do they automatically check, where's the communication
So
between?
can I just interrupt, because I had a question here a while back, and
Oh,
everyone's,
sorry.
and I'm going to give you an answer for that, but because Terry just reminded me of something that we used to do all the time.
I actually have kind of an answer to that. There's actually a program on cell phones, any cell phone, where you can have an emergency contact that all ambulances can access, and it's an and you can put
Is that
your
Android or Apple?
any phone.
Okay.
Any phone now comes with a program where it is an emergency contact, and there is also an ICE program that is on all electronic devices where you can put in your information.
Okay.
Where you have DNRs and stuff like that, your medical history. So
is it an app or is it on everyone's
it's actually
phone?
on your phone.
Okay.
If you go into your
Okay, so we'll.
yeah, that's if you don't have one. I'm just saying this is for
Okay.
electronics.
Okay, so that's good to
But
know.
again, that's really important, like making sure that you have someone who speaks for you when you can't. But as Terry just reminded me, if you have a condition where you know you're passing away, your life's going to be shortened, we fill out forms that allow what's called an expected death at home. And we let the coroner, I think we let the coroner know, we let the RCMP know, we let public health know, we let BC ambulance know. I don't know if that's still happening because it wasn't well used, but it is important because
it's still a form. We don't have it in that kit. We should probably put it in.
Well, I think that's something we fill out, isn't it?
Oh,
Yeah,
the
it's something that
doctors?
we have to
Okay.
fill out. Yeah, but Gail,
Is the DNR still a form that we use?
no CPR.
No, yeah, DNR.
You know what? I'm not sure, Gail.
Because that was one thing
I
that
think
we used
you
to
could,
have.
yes, and that would still be. I mean, you look at the dates on these various forms. So if you had an old CPR, no CPR, CPR on your fridge, and the most is the more recent. I've put the most up, and I apologize. This is not, I should have brought my own projector because honestly, I can't even read it, and I'm right here. But that is essentially this one at the top, which is just comfort measures only, and this one at the bottom, which is the full meal deal, is no CPR, CPR. And then all the things in between are different levels of care that you agree to after talking with your physician. And you can change your mind if you're awake, alert, and deemed to be capable of making that decision. If you're not capable of making that decision, then, as you see right here, it's got in here these representative agreements. Something else, these are all the reasons why we're doing what we're doing. And then substitute decision maker is on there too. But, making sure that you have, like people will put these on their fridge. And that's probably the best place to have it because theoretically, I don't know, you're search and rescue, right?
Yep.
Yeah, but do you guys ever deal with this?
No, we don't deal with anything like that.
No.
Just strictly motor vehicle accidents.
Yeah. So you're climbing down the cliffs and getting people. Yes. I'm not sure. Is there anyone in here who does ambulance?
What was your question?
There's a question over here.
Sorry,
It's
Lorraine.
not the ambulance, but we have had situations in this town where the ambulance isn't available, and the fire department have had to deal with cardiac arrest.
Yeah.
And so they pretty well have a protocol that they have to follow, even though, say, a loved one was there that said no CPR.
Right, I know. Yeah.
So are the fire department in with the ambulance on this? Because they
I can't answer that, Lorraine. That's an excellent question, but I can't answer that. That you would think common sense would say that they should get the same.
Well, we need the ambulance people to come in next.
Right? Volunteers, they're not trained in medical.
No, I mean,
Okay.
and honestly, the BC ambulance is great. It's amazing they're still providing a service for these little towns because they're all stretched, right? But they have. We don't have advanced cardiac life support here. We have to call it in. So these guys are basic life support, most of them with extra training on certain things. And no, the fire department, they'll get, I imagine they get, basic CPR and that sort of stuff. Pardon me?
AEDs.
Yeah, exactly. Yeah. But with the most, do people want me to go through this line by line?
Yeah.
And, well, I know you won't, Gail. Do people want to, because that was what thing Kim said was really important, is for people to get an idea of what the various things mean, what they call them life. How did you put it? Life
Interventions.
No, yeah, I get the intervention thing, but no, it's life. It keeps you going, right?
A life support?
Yeah. So no, there. That doesn't matter. It's semantics, right? But CPR. When I was a young physician, we went to advanced life support and were taught about CPR. They had huge algorithms that you had to follow. If this happened, you went to here. If you went to here, this happened, you went to here. Really difficult to remember, consequently really difficult to do properly when you're faced with someone who needs this. Thankfully, they followed the KISS principle, and it's pretty simple now. Partly because research started to show that CPR does not prolong your life for very long. It's there as a stopgap except in some really rare circumstances like hypothermia or drowning. It only allows a short period of time before you start to have irreversible, usually neurological damage, but it could be other things too. So you may remember better than I do, but I think it's like after sort of 4 or 5 minutes, isn't it? That you can start to have damage, neurological damage. If you get into 10 minutes, you're starting to have irreversible neurological damage. So let's say, use myself as an example. I've had multiple heart attacks. Your heart's a pump. The more wall of the heart that you damage, the less the pump works, so it's not as efficient. And I've got a little piece of pump that's going, just trying to keep me at rest, breathing. If I have a heart attack, there's not much left. I don't want CPR. That's me. I'm not trying to give you guys your advice. I've had people who want everything done, and you kind of wonder if they really understand where they're at. I failed in my job there, but CPR buys you time. So if you have a condition where you're progressively getting worse over time, despite maximum medical therapy, CPR is buying you time, not really for anything, right? So that's the thing, and that is, it depends on the condition. And like I said earlier, when I had my hip replacement, if I had a heart attack on the bench, I want him to do it because, I was hiking up hills before with a big pack on my back. So I think I've still got a lot of heart muscle left. I may be wrong. I may wake up and have massive damage, but you don't know that, right? That's the problem with all of this stuff. If you had a crystal ball, you'd know what to do. But these other temporary, like specific intervention, blood products, that's often there because of certain groups obviously don't want blood. And some people just object to having blood products. But, there are patients that have medical conditions where their bone marrow doesn't produce blood anymore. So they can have blood products. It is life-sustaining. They'll have blood transfusions every, few weeks or months to keep things going for them. Nutritional support, that is, it's as a temporary measure. Someone who is having, say, esophageal cancer, they're going to have surgery so they can no longer eat for a while. That could be a temporary measure while the surgery is done in hopes that they will eventually be able to go back to swallowing whole food. But some people end up with a feeding tube because of damage to their esophagus that doesn't work anymore, and they're fed through a tube in their tummy. Now, if you're completely healthy, fit, you may choose, I want to do that, right? But that's the kind of stuff that's referring to. And the non-invasive ventilation, that refers to putting a mask on you to provide pressure to help you breathe. Because when you're sick and unable to breathe, you've got pneumonia, your respiratory muscles tire very quickly. And if you've been sick for a while, you may not be able to breathe anymore. Your choice is intubation, which is a tube down your throat, and a machine to do it while we try to treat the pneumonia or whatever else is causing it. Or sometimes having this pressure. What do they call it? New one? Oxyflow? Yeah, that's BiPAP, but that little machine they were getting up here, the Oxyflow or something like that. But it provides extra pressure and helps you temporize things for you while you recover from the underlying condition. Like the Pope. Yeah, there's a good example. When they talked about him being on special treatment, they were using that for him.
I just want to go back to the...
Just one sec, Ken. Sorry.
Good morning.
Good morning. Ian. Not a doctor.
You're still Dr. Routley.
Okay.
All the years I've known you, even though you're retired.
Yeah.
Anyway, it's different for on reserve, isn't it? Or is it the same?
It's the same. The most forms should be exactly the same, no matter where.
Give it to me, so I'm going over it.
Pardon me?
I decided that, when I do my will, I'm going to have two executors. One is for family, the other one is for finances.
Right.
Mm-hmm. And then when I die, everything that they have to follow is what I write in my will. Because if you don't have that, a lot of members on our reserve don't have this.
Yes.
It's really hard to acknowledge to what we need to be done.
Yeah.
So I'm really glad you're having this so I can understand a little bit more.
Yes.
So I'm preparing myself.
This woman here, Kim, gets the thanks, but that's really good for you to do, for sure.
Yeah, if you go to the hub, you can actually pick up a kit that goes through all the different forms that you need, and the most is included in that, where you have to see a doctor. Oh yeah, there we go.
Yeah,
And you've got and there's actually an Indigenous focused life planning. It's all the same forms and everything, but it's just coming from an Indigenous perspective, which is really, really. I thought it was actually really, really nice. Yeah.
And it's really good to have your family doctor on your form, because this way the ambulance attendants and when you're about to go, they'll have that information.
Yeah. So one sec, Sharon. I just
I just wanted to clarify whether or not the ambulance has access to whatever system they have to access these types of forms, because I know a personal
event
situation I had. I knew the person's most designation, and I said they don't want CPR, and then she couldn't verify that.
Yeah.
Until a doctor said that they could stop, so they had to keep on going.
Yeah.
I'm going to check with
And
the
that was
ambulance.
my father, by the way. And
Yeah, it's tough.
I knew that he didn't want.
It's tough.
So,
Yeah.
So I just want to know, is the ambulance going to have access to that? So that
I'll ask them and see where they're at with that. Like, how do they
said,
go
"Do you
about
have
it?
a copy of the form?" And I said, "No,
Yeah.
because it's with Interior Health, with the most office." Right.
Yeah.
You fax it to the most office.
Yes.
And then they put it into the system.
Yeah, you would think they would have access to it. That's what they say. But again, back to the green sleeve, if it actually is happening at home, they are supposed to look for a green sleeve.
Yeah. But if there isn't, they still have their advanced directives or their most
I don't know.
documented in the system, in Meditech or with Interior Health.
I suspect, that the way the system works, that the BC ambulance would not have access to interior health forms. So when and I mean, there are probably people I didn't do this with because you just forget sometimes, but I would always try to fill out a most. You have to fax it into the most office in interior health. But then the original copy would be photocopied. One copy would go on the patient's chart, and then the original would be handed to the patient or the family member that came in with them, so that they went home with it. And I always told them to have it somewhere where it's prominent. Now, if you're your age or my age, and you're thinking, "Oh, I'm not elderly," you're not going to put it on your fridge, right? You're not. You got your grandkids like drawings and stuff on your fridge. You're not putting your most up there. And just, as an aside, I grew up in a family. My sister and I was 10, so my sister was 8. My grandmother, who grew up in this town, by the way, she had quite advanced dementia at the end of her life. And in those days, doctors didn't ask what you wanted. They couldn't care less. They just did what they thought was best. So my mother started telling my sister and I, before we even knew what the heck she was talking about her wishes when she got to that age. So, it's communication, but it started a little too early. But yeah, it's frustrating, Harvey. I get it. I mean, I can't, but I could tell you horror stories about police showing up at houses with an expected death at home, but no forms, and just like starting an investigation. And oh my God, yeah, some of this stuff.
That's why it's important to have your forms
and have family members that are aware
of it.
Yeah. Sorry,
here next.
Sharon.
At the senior. Oh.
Okay, I was just because I was in a hospital with the cancer, and I had my stomach pumped out. They were giving me food to intravenous,
right?
And you're talking about doing it. Like,
yeah, sorry, Ken. There's other ways for sure.
I was just curious. Can you put down a position that if you were in a position where you wanted to eat, you want to make sure you get intravenous instead of the.
It depends on the circumstances.
Okay.
And it really depends on the circumstances. So, I mean, theoretically, your physician, given your circumstances, would talk to you about what your options are at that time.
I was just curious because of what I went through.
Yeah. Yeah, no, for sure, Ken.
Thank you.
Yeah, you're welcome. I think Sharon had a question, and then we'll come to you. Okay, Sharon.
Yeah, the seniors have a defibrillator.
Right.
machine. How does that affect this? Is that something to think about? If somebody.
For sure. I mean, the bottom line is, hopefully you guys all know what your wishes are, or there's some way of knowing it. Because if you start a defibrillator, that's that.
Oh, really?
That's C1, or sorry, C2. That's right here. Critical care interventions, including CPR, defibrillation, and then the rest. So yeah, that's C2. So a defibrillator. I mean, what the theory is. Pardon me?
Is that invasive to the body, a defibrillator?
Not invasive in the sense that you're not entering the body, but it's pretty invasive if you've ever shocked somebody.
And it's part of CPR too, right?
It is. Well, if you've got a defibrillator, it's part of CPR for sure. Yeah. Sorry, I've got one more question, then you, Stu. Yeah. You had a question?
No, I used to have a bracelet with DNR on it.
Yeah.
And I think that's a good way, to have that bracelet, and then if the ambulance were to enter your house, they would probably look at your fridge to see if
Yeah.
That's a good idea.
Yeah, that is good. It can't give you the subtleties of this, and as I said earlier in the talk, the advanced directive is even more. You can put more nuance in that if you want. So, if you say I have a 50% chance of surviving, I want everything done. Right? You can't put that on the most. But if you're awake and alert, you can tell the person that.
Yeah.
And I mean, you can't. I mean, no doctor can predict accurately. We try to, but you can't, obviously. So, I'm sorry, Stu?
That's fine. I just, the pacemaker.
Yes.
Can you have the shock?
Yes. But help me out here. There's no reason why you can't. You just don't want to put the thing right on top.
As long as it's not an automatic defibrillator.
Right. Yes. Good point. Yeah. It depends on your pacemaker.
Well, I've heard. Oh.
Yeah. So if you have a pacemaker that also provides defibrillation, I have to ask Terry. It's been 3 years since I've worked in that place regularly, and I forget everything every day. But yeah, no, you don't want to put the paddle over top of the defibrillator. But if it is a pacemaker defibrillator, theoretically, and we usually as physicians can tell that because you can hear it. You can sort of, you can get the jolt that they're getting from the thing. You get the little muscle twitches, right? So if it's already not working, the chances are Yeah.
Let's say that you don't want all intervention for life.
Right.
And you've elected someone, let's say your daughter or son or whatever, to make decisions for you, and you come out of it, and your quality of life isn't there. Can they make a decision for you that you want death by chemical, or that you can carry on with death?
That's Terry's part of the talk, Len, but I think I'd be safe to say not in that circumstance, correct?
Yeah, there's no advanced consent available yet.
Is that right?
It's in legislation.
But can you, even for the doctor?
Unless you move to Quebec.
Yeah, no, so
then they become the 51st state.
No, if you became the 51st state, you wouldn't be doing any of this. Honestly. The problem with not the problem, but the deal with MAiD that you hear people always getting wound up about is exactly the circumstance you're talking about. So maybe you've got a big inheritance and I want it. Is what they think people are going to do, which is preposterous in 99.9% of the time, right? But you're on the flip side, you're completely ignoring the MAiD part of the question. If your person that you've given the ability to make decisions for you knows what your wishes are, and you've said, like, if I have this type of quality of life, I no longer want treatment. So they could then switch your thing to either M1 or M2, which means comfort measures only M1, or M2 is treat conditions, but if you continue to deteriorate, despite, let's say you got a pneumonia, and we gave you antibiotics, and you just kept getting worse and worse, we're not going to ship you off to Kamloops, put you in an intensive care unit, well, you wouldn't intubate with an M2 anyway, but you wouldn't put them in an ICU and hook them up to drugs that might help your condition. So they could make that decision for you.
See,
but your MAiD's out of the question.
My point of view is, I don't want to be laying there just extending my life because I'm going to hang on. I'd rather just have it over with.
Yeah.
And I think that's something that a lot of people would want more than just laying there.
Yeah, and that's why it's important to try to do this stuff for yourself, because most of us aren't going to die in our sleep, right? Most of us are going to have something else that happens. Some of us will be fortunate enough to go to bed at night and not wake up, but most of us aren't. We're going to have some other ending. And you just don't know what that's going to be.
I was just wondering if you could repeat the questions and voice up a bit. We can't hear you.
You should have been here earlier because my voice was stronger then.
Right here. There's one chair back up here, and this one's
it's repeating my questions.
Well, but everybody.
Yeah, there's one there.
And if you repeat the questions, then the
I know, Betty. I heard, and I will. Yes.
Thank you. And if Terry speaks, if he could stand up so we could hear him too.
I'm just asking him to help me. He's not. He's not even here. Yeah. So, you good?
Oh, just one little simple question.
Sure.
How often do you recommend reviewing the most for?
It's an excellent question. So did you hear the question? She asked how often I recommend reviewing the most, this form here, or any of your documents that have to do with what your wishes are. When circumstances change, there's no hard rule for it. But it depends on the person. Like, I'd probably look at it every year just to see what did I do, because now it's going to be every 6 months because I won't remember what I did. But anytime your circumstances change.
Yeah,
so
I knew the answer, but
no, perfect. So, is that it, guys? Questions all? Yes.
Do doctors always tell people their chances of living or dying, like the condition?
Did you hear that question? Your friend didn't, though. You didn't hear it. Do doctors always tell people their chances of living or dying? I didn't. I would say you have a higher risk of passing away from this in the next year. So an example is someone with severe lung disease or severe heart disease with chronic congestive heart failure at rest. They have a 1 in 2 chance of not making the year. Now, everyone here knows someone with that condition that's lived decades, right? But statistically, you have a 1 in 2 chance of not making it through the year. But it's never black and white like that, because that person may just have the lung disease and nothing else. You're guessing at best. And being told that disease is going to shorten your life, but I can't say by how quickly or how long. I never felt comfortable telling people.
What if they are terminal?
Pardon me?
What if they are terminal and the doctor knows it?
Well, we're all terminal, first off, and I don't mean to be facetious when I say that, but I was constantly humbled by how often I got things wrong in terms of how long someone was going to survive. What I thought they would want, too, because a lot of times people's wishes, you have to ask. They don't always tell you. But yeah, no, I mean, if someone has a disease that's going to end their life, I mean, if it's someone with advanced lung cancer, advanced liver cancer, advanced prostate cancer, any of those kind of cancers, I will tell them. But I mean, I just learned of a friend last night who is not doing very well, and I traveled with him in 2019. He had advanced prostate cancer then. And you know, it's how many years later? It's catching up with him, right? So, I mean, I didn't know he had that at the time. I mean, he told me when we were traveling, but I wasn't his doctor, so I don't know the full story. But
so that's where palliative care kind of comes in, where you treat some of the
symptoms, and it loosens things up. Like, people have a lot of myths around palliative care. They think it's end of life only. It means you're giving up. You know, you're going to die soon. None of that, with proper palliative care, none of that actually, they're all myths. You're going to be knocked out on morphine. Yeah, we'll give you stronger painkillers, and we'll be able to do it in a way that doesn't sedate you all the time to help you with symptoms if you have them. And hopefully you don't get the stigma of the pharmacist sort of, you know, looking at you as though, why are you coming in here for these medications? Here you wouldn't, but if you go elsewhere, sometimes that happens. So, yeah, palliative care, it also has a bit of a financial benefit to people in BC, but it's only 6 months, Terry. It's more like I mean, yeah, we would say this person has 6 months to live. I'll fill out the forms and say to a person, I'm going to start you on palliative care, because, you know, they may have been financially struggling to buy the various things they need. So we fill the form out. And I put down, knowing full well the chances are they're going to live a lot longer than 6 months, I will tick the box saying I don't think they have 6 months. Because it's a bit unfair to wait and make them suffer and not be able to get access to stuff. But, yeah.
The government asks for the 6 month time frame, just so that they will fund it.
Yeah.
So it's really, like you say, it's a financial thing.
Yeah. Yeah. Yeah.
Nobody knows whether you're going to last 6 months, and you can renew it after 6 months.
Yeah. Right. And you don't, I mean, I never ever had the government come back at me and say, man, you don't know what you're doing. Did you hear that question?
And so palliative care can happen in your own home, right? With the home care support people.
All this stuff can, if you have, I mean, I don't know about Lillooet so much anymore, but if you have the resources. A lot of places struggle for the resources. Like, we don't have the dedicated physiotherapy. We have a great physiotherapist who comes and visits, but he just does so much and not necessarily this sort of stuff.
And then there's hospice, right? Like, so you have palliative care, and then when it is the end of life, there's the hospice, and the hospital has one hospice bed, right? Is that right? Like a hospice room?
No, that's, I mean, yeah, it's hospice is a specialized, I said that in the talk. Obviously, Kim was out of the room at that point. But hospice care is a specialized palliative care that is definitely the last 6 months of a person's life, theoretically. So, you know, when I'm filling out those forms that say 6 months that the government has for financial help, and you get access to things that they don't usually pay for, dressings, other things they may not pay for, that's kind of hospice care, right? Because you're saying this person is not going to last for more than 6 months. And there's a room in the hospital that, at least when I worked there, when we were full and there were no other rooms and you had to put someone in there that was going in there for something not to do at all with terminal care, everybody kind of knew what the room was. But honestly, guys, it's the best room in the hospital. So, I mean, if you get in there, be thankful. Your family can stay. There's a nice bed. There's TV. There's microwave. There's everything. So,
well, are you changed over from palliative care to hospice or whatever that word is.
Hospice,
care,
yeah.
advised by a doctor, or the family can make that decision for and ask for it, or?
That's a really good question, but this is kind of the semantics of all this stuff. In other words, the way different people define it. I mean, hospice care is acknowledging that you're not going to recover from this condition and it's going to significantly shorten your life. It's more a discussion. I've had people who, right up to the very end, are just they're in denial. And that's, they're just not willing to acknowledge it or talk about it, you know. And that happens. That's just, you know, certain circumstances. So, but yeah, this is more a discussion with you, with your physician, with your family, and your understanding of the condition. We would talk about saying this disease is going to be significantly life-limiting. And most people know, even the ones who I mean, I've had people who wanted MAiD and at the last minute said they wanted to think about it some more. And I'm sure, Terry, you've gone to give MAiD and
So do we want to have like a 10-minute break?
Yeah.
And we have some drinks here and some snacks if anyone wants. And then we'll move into MAiD then? Or do you have more to talk about, Ian?
No.
Okay, we still